Let's see. I'll just cue you to start the video and stop it.
So how would your shot be shooting over this?
Okay. Well, it's all right. Okay. My name's Blake Simpson, and I'm in the otolaryngology department here at the Health Science Center. And I'm fellowship trained in voice disorders, and most of my practice deals with laryngology and voice disorders. So a topic that's near and dear to me is hoarseness in any patient, and especially the geriatric patient, because it as I've been here in San Antonio over the past 4 years, I've had really a good portion of my patients that come in with hoarseness are geriatric. So this is a topic I've dealt with a fair amount in the last few years. What I'm going over today really is, first, there's really 3 important points. First is just an overview of the common etiologies that I see as an otolaryngologist when a geriatric patient presents with hoarseness. So you'll be familiar with probably the 7 most common things that I see. The next is the red flags, things that should make you worry in a patient's history, worry about they may have something serious and need early referral to an otolaryngologist for their hoarseness. And the third thing is there really in the last 5 to 10 years have been a number of treatments for voice disorders that have come into being that really make a big difference in the patient's voice that we really didn't have years ago. So just a brief overview of how do we produce a voice to begin with? Well, obviously, you have to have an air source to produce voice, and the generator of that air is obviously the lungs. Then when the airstream comes up, you need something to chop up the airstream, and that's the vocal cords. They are sort of the vibrator. Once the sound is produced, and actually if you've ever heard the vocal cords outside the body producing a noise, it's just a buzzing noise. It's not a very pleasant sound. And what really makes the voice pretty is the resonating chambers in the pharynx and the nasal cavity. Once the voice gets out to the front, that's where the articulators come in, the tongue, the lips, the jaw, and that's what actually produces words. That's what produces speech, which I'm distinguishing from voice. Now what happens to somebody as they get older is a number of things change, as you can imagine, that alter voice production. The lungs, there's a reduced pulmonary capacity in most of the geriatric population. This actually does affect the voice because this is the way that the airstream is brought into being through the lungs, so that will affect the voice some. In terms of articulation, as you get older, the pronunciation of consonants becomes imprecise, and there's a slower rate of articulation, and that actually affects our perception of the voice. But I'm not going to really concentrate on those so much as what is happening at the level of the vocal cords, because this is really where most of the problems come in with voice production in the elderly population. And there are, as you can imagine, age-related changes in the vocal cords that produce changes in the voice. And they're really, you can divide them into, they're independent of each other. The vocal cords in males tend to undergo different changes than the vocal cords in females. As males age, you get really predominantly muscular atrophy of the vocal cords. And I'm going to show you some footage of this. This will produce what we call bowing of the vocal cords, or it's also called presbylaryngis. You may hear these 2 terms used interchangeably. But what the end result of this is a weak, breathy, sort of reedy, high-pitched voice. And whether you realize it or not, this is a big part of how we identify somebody's age. If you're talking to somebody on the phone and you're listening to their voice, you can generally get an idea of how old they are. And it's this characteristic in the male voice that tends to set you off, that breathy, high-pitched quality that older gentlemen get. In females, interestingly enough, the pitch does the exact opposite. In females, instead of the pitch going up, it tends to drop down and become more masculine. Now, women can undergo muscular atrophy of their cords, but it is not the predominant effect. The predominant effect is this edema, and we believe it's due to hormonal changes that occur around menopause. And I'll talk about that a little bit later, but it results in a rough, low-pitched voice. So voices are going in opposite directions as people age. Now I looked through my list of my clinic charts for the past 4 years to see what was the most common disorder I saw in the geriatric population. Here are the most common ones. Number one, and I'll talk about this first, is presbylaryngeus. We've already sort of hinted at that, but I'm going to show you a videotape. Postmenopausal voice is common. Side effects from medications. Laryngopharyngeal reflux or acid reflux into the larynx. Vocal cord paralysis. And then I sort of dropped all neurologic diseases together. Benign essential tremor, stroke, and spasmodic dysphonia are probably the three most common I see. And then obviously what we all worry about when someone is hoarse, and especially if they're a smoker, is squamous cell carcinoma of the larynx. So these are the most common things I see, and I'll talk about each one of these and show you videos of each one. Now, presbylaryngeus, already mentioned, also called vocal cord bowing, is definitely age-related. In fact, I almost never see this in somebody younger than 60. It can occur rarely in a gentleman in his 40s or 50s, but it's almost always over age 60. It's predominantly male, and it's due, as I mentioned before, to muscular atrophy of the vocal cord. And as I mentioned, they complain of a weak voice, vocal fatigue, and it's usually higher pitched voice, although I'll show you a gentleman that's a little bit different from that. There are treatments for this, and that's the real key thing that's come into being over the past 5 or 10 years. There are great treatments for this, and we can really make somebody's voice sound significantly better. And there's a medialization laryngoplasty. That's the most common thing I'll do. I'll show you some before and afters of somebody that's undergone this procedure. And also, you may have seen this on, I think it was 2020, there was a gentleman that was injecting collagen. Dr. Burke in LA is injecting collagen for patients with vocal fold bowing. And it works very well, but it only works for a few months. That's something to keep in mind. Medialization laryngoplasty is a more permanent treatment. The first video I have is actually a gentleman that has presbylaryngeus. Now, I mentioned earlier they tend to have a high-pitched, weak, breathy voice, and this gentleman actually has compensated, and he's got a lower-pitched voice because he's trying to get that gravelly voice, that more masculine voice. But when you hear him in the second portion of the video, you'll see the high-pitched quality of his voice. Before I show you him, I'm going to show you what is a normal larynx, and if you could cue the video on that. The first footage you'll see here is actually our speech pathologist. This is a normal looking larynx, so you'll know what to compare this in the future. The vocal cords are these white things right here that form a V. And you'll see when she phonates here, the vocal cords come together. They touch, and they should pretty much close from front to back. That's normal vocal folds. This is presbylaryngeus. Can we boost the volume? Now, he doesn't sound high-pitched, but listen to him here. This is what his voice sounds like. This very breathy. You can hear the air, and there's bowing of the vocal cords. And you can see the definite gap there. You can stop it there. Sorry, no gaps in these.
Excuse me, in the normal anatomy, what is that, something through vocal?
Right, the normal anatomy, the true vocal cords are right here. They're white. The false vocal cords are these pink things on either side.
Okay.
And I showed you, the first video I showed you was the vocal cords coming together and closing off completely. This is an example of vocal cord bowing. You see the vocal cords touching, and there's this football-shaped or elliptical defect right here. This is due to muscular atrophy. Air escapes. It gives it that breathy quality. Because of the thin, reedy quality of the vocal cords, that gives you the high pitch. So that's presbylaryngeus. Far and away in males, the most common cause of hoarseness of patients that are referred to me. It's really physiologic. I mean, it's effective aging, but it can be corrected, and I'll show you that a little bit later in the talk.
The vocal cord, the tissue is cartilage mostly, fibrous tissues?
It's really muscle. Really, the bulk of the vocal cord is a muscle. There's some connective tissue that's superficial to that, but the bulk of the vocal cord, probably 3/4 of it, is made up of muscle.
So the atrophy is the muscle, they're not in the sustaining apparatus?
There's both, but the main reason why they get the weak, breathy voice is because of the muscular atrophy. But there's really atrophy of everything. The mucosal cover, the submucosal tissues, and the muscle itself. Postmenopausal voice, I also see a fair amount of. I don't know that women tend to come in specifically complaining of hoarseness, and this is the cause, but it's just a minor annoyance usually. They rarely come in to see their otolaryngologist for it, but you may hear it a lot as primary caregivers. They may say, well, my voice changed. Once I turned 50, I can't figure out why. And it's not completely understood. We know the female vocal folds after they reach menopause are more edematous. That's been shown. And no one's really sure why. We know it's hormonally related, and the most recent theory is that it's the estrogen-androgen, I don't know if I'd call it testosterone, but the estrogen-androgen balance. And as once estrogen decreases, there's a relative increase in androgens, and that may cause the masculinization of the voice. But they complain of a rough voice, it's a little bit lower pitched, and it has been theorized that hormone replacement therapy, which most, or I won't say most, but many women are on, is a reasonable treatment for this. And I have an example of postmenopausal voice. It's the next one. I think about half of the segment already played. You may have to rewind a little bit. But the pitch drops about, I don't know if there are any musicians here, but it drops about 20 to 40 hertz, which is fairly low, almost starts to approximate male voice. If you can play that.
Apparently beyond
You can hear she sounds lower pitched. The vocal cords are edematous. You can see they're fatter than the vocal cords I showed you before. You can stop it there. So the vocal cords become edematous, they're fatter, and that drops the pitch. Postmenopausal voice is fairly common. Now, we're really not sure if hormone replacement therapy corrects it or yet, but it's the best treatment we have for this condition. This is also fairly common in the geriatric population.
When you say postmenopausal, how far postmenopausal? You say
Well, it begins after menopause, and unless something's done to correct it, it will continue throughout the patient's life.
You see, usually may happen shortly after menopause.
Yeah, if you look at the frequency of women's voice, the pitch that they're at, right around 50, 55, it drops down about 5 or 6 semitones and just stays there until death, really. There's really not a drop after that. It's just a precipitous drop around menopause that stabilizes and stays right there until late age. Medication side effects. You can imagine a lot of geriatric patients are on many medications, and there are a variety of side effects you can have from medications, but really the number one I see is drying medications causing problems with the voice. Anything that dries the mucous membrane, and of course the category of those medicines is, I could never list it. I brought a handout that we can actually send off if anybody wants it, listing most of the medications that are associated with drying. But anything that dries the mucous membranes is going to dry the vocal cords, and it's been shown time and again vocal cords do not vibrate well in a dry medium. There's really poor vibration. This causes hoarseness, pitch breaks, a number of problems. So anything like antihistamines, diuretics, tricyclic antidepressants, SRIs, phenothiazines, and many hypertensives can cause drying and can cause hoarseness. And I haven't had a lot of success with this. I usually tell the patient that they have dry, thick mucus on their vocal cords, and if they could get off certain medications or maybe be switched to other medicines, it would help. So if you can substitute other non-drying medications, that will be very helpful. The next video tape I have is somebody that's on a number of drying medications, and you can see, I'll show you the white, thick mucus that's developed on their vocal cords. And again, this thick mucus interferes with vocal cord vibration, causes a roughness, causes voice breaks. It's very problematic. The white things you see here that's kind of stranding across the vocal cords, that's thick mucus on the surface of the vocal cords, again from the drying effects of medications. The patient can cough it up. They're going to continue, their mucus glands are going to continue to produce this thick, viscous mucus. You can stop there. Next this disorder has really gotten a lot of attention, and especially in our literature over the past 10 years, and that's acid reflux that gets up to the larynx. Or we call it laryngopharyngeal reflux, or LPR. But you may have also heard it called GER laryngitis, or gastroesophageal reflux laryngitis. And what happens is, we all know acid reflux can get into the distal esophagus, but in some cases it can get all the way up into the throat and even damage the larynx, and it's not as uncommon as you think it would be. What actually happens is gastric contents, which includes acid and pepsin, get up there and irritate the vocal cords. And actually the thing that does the damage, you would think it would be the acid that would damage the vocal cords, but it's actually the pepsin. That's a digestive enzyme, but pepsin is acid activated. So the combination of the two is what causes the damage. Now the patients often have hoarseness. Obviously this is a lecture on hoarseness. They present with hoarseness, but they have other complaints. And one of the ones to look for that we see a fair amount is Globus Fringes. Globus Fringes is a sensation of a foreign body in the throat. So they say, I feel like I have something caught in my throat. If you just look down there, you'll see it. Usually there's not anything down their throat. It's just this reflux causing irritation in the vocal cords that gives them a sensation of globus. Makes them want to clear their throats. So a lot of these people are chronic throat clearers. And the way you treat laryngopharyngeal reflux is with, obviously, everybody's familiar with reflux precautions, elevating the head of bed, avoiding fried and fatty foods, caffeine, tobacco, alcohol, things such as that. And we also put them on a proton pump inhibitor, which may seem fairly aggressive, but laryngopharyngeal reflux, you really need to shut off the acid almost entirely to get control of it. And I'll show you some before and afters of LPR. This video is a good example. If you got the next video, cue the next video. A good example of what somebody's vocal cords look like after it's been exposed to acid. This is actually a gentleman from the VA, a non-smoker, never smoked a day in his life, that has fairly severe acid reflux. You remember before the vocal cords are white. Look how red these vocal cords are. They're almost the same color as the surrounding mucosa. And there's redness in the back part of the larynx and even a little bit of, you can shut it down there, even a little bit of leukoplakia. I'm going to show you that gentleman in a little bit again because he's somebody we treated with proton pump inhibitors who got significantly better. But LPR is another common cause of hoarseness in the geriatric population. Vocal cord paralysis. Now, the first, I guess, 4 conditions I showed you may have minor degrees of hoarseness that you would almost, maybe not even hear when you examine the patient. All of the remaining causes of hoarseness I'm going to show you are obvious. I mean, you see these people, you can tell they're severely hoarse. Vocal cord paralysis, especially right after it occurs, these patients are going to be extremely hoarse. And I'll play you a tape of a gentleman with that. The causes of vocal cord paralysis, really the number one cause is iatrogenic from a surgery, thyroidectomy, esophagectomy, base of skull surgery, anything that could cut the recurrent laryngeal nerve. Anything in the neck or upper chest can cause vocal cord paralysis. Cancer is actually the most common cancer to cause vocal cord paralysis is bronchiogenic carcinoma. And it's not the cancer in the lung itself, it's when they metastasize to the mediastinum. You get a big lymph node in the mediastinum that puts pressure on the recurrent laryngeal nerve as it dips into the chest. A stroke is obviously another common cause of vocal cord paralysis. And we used to call it idiopathic, but we think many of these quote, idiopathic vocal fold paralysis are probably herpetic infections that get into the recurrent laryngeal nerve. So viral causes are seeming to be more and more recognized. What the patient complains of is a very weak, breathy voice, much more so than the gentleman you saw with presbylaryngitis. These people have, they're hardly able to talk in the early stages of vocal cord paralysis. And the other key part of the history is they will often complain of aspiration of liquids. When they drink anything, water, tea, anything that's a thin liquid, it tends to be aspirated because they can't protect their glottis because of the paralyzed cord. And they are at risk for aspiration pneumonia. If you at all suspect this vocal fold paralysis, you need to send them to us to take a look and confirm the diagnosis and to send them to a speech pathologist so they can do a modified barium swallow, look for aspiration, and hopefully provide some therapeutic strategies to avoid aspiration. If they can't get the patient to keep from aspirating, they're going to have to make them NPO, obviously. But there are surgical treatments for vocal cord paralysis, medialization, laryngoplasty, or vocal cord injection. I'll show you an example of that in a little bit. This next patient is an example of a gentleman that has vocal cord paralysis, and he actually had a large mediastinal lymph nodes that caused paralysis of his recurrent laryngeal nerves as it dipped down into the chest. Very weak, very breathy voice. You're not going to miss this severe of a hoarseness. If you look on the screen, the right side of your screen is his left vocal cord. It's not moving. You can see the opposite side moving, trying to touch it, and he's got a big gap there. It's not hard to imagine that liquids could sneak down and be aspirated when you've got such poor glottic closure. And that's exactly what happened with this gentleman. You can stop there. I'll show you a treatment of that in a little bit. But it's a very treatable condition. Spasmodic dysphonia. is not an extremely common disorder, but it's often misdiagnosed. And I think when you hear the video of this patient's voice, you'll realize why it's often misdiagnosed. Far and away, female predominance, about 3 to 1. I have a fairly large group of patients with spasmodic dysphonia, and out of the 50 or so I'm treating, I would say mine's even higher female predominance, maybe 40 out of the 50. It is neurologic in origin. At least we think it arises in the basal ganglia. And the complaints of these patients, and you can't miss the hoarseness in their voice, but they'll complain they can't get their words out. They feel like something is cutting off and spasming in their throat. And the way their speech is described is a strained or strangled type of speech. And there's actually excellent treatment for it. We're injecting Botox or botulinum toxin into the vocal cords, which is quite effective. But if you can play the video, this is a lady with spasmodic dysphonia. Fairly typical case. I would say it's moderate to severe in nature. You can hear it sounds like she's being strangled. You hear words are almost just literally chopped into two. And watch your vocal cords spasm. You'll see the false vocal cords squeezing towards the midline. And that's the best she can do. She can't hold out a note more than a few seconds. You can stop that there. So I would say before probably the 1960s, this was originally called spastic dysphonia. And people thought it was actually just functional in nature. And it wasn't until much later they figured out it was actually neurologic and could be treated. They used to cut the recurrent laryngeal nerve to treat this condition. I wouldn't recommend doing that anymore. Botox is really the standard of care.
Excuse me, when you say neurological in nature, how, in which way? What do you mean? So,
Well, we just know where it arises. We know it arises in the CNS. That's about all we know.
it's centrally mediated, you mean?
Right. Somewhere in the basal ganglia. That's about all they know.
Do you listen to public radio?
Yeah, Diane Reams.
This is what she got, right?
This is exactly what she has. You're correct. And actually, I present this in a geriatric talk, and because most of my population that has this is 60 and above. But the truth of the matter is the average age of onset of spasmodic dysphonia is probably close to age 40. But it's usually from when you get the disorder to where you're finally correctly diagnosed is about 10 to 15 years. So these patients come in to maybe their primary care physician who says, well, maybe it's allergies, maybe it's something else, and they don't get into the right hands. Because even I wouldn't say most, but many otolaryngologists even can't correctly diagnose it because you have to have heard a number of these people. It's really a diagnosis you make with your ear. You can't send a blood test. Really, the way to make the diagnosis is listen to the voice and be familiar with it. So it's commonly misdiagnosed. There's a ton of people out there that still probably need to get a correct diagnosis. And that's why they finally present as a geriatric patient, because they've been misdiagnosed for years. Vocal tremor, also see a fair amount. There's a number of causes for vocal tremor, but the most common cause I see is benign essential tremor. And if you remember some neurology, you'll remember these patients can have tremor in their head, their hands, and their voice. About 60% of cases are familial, and it's autosomal dominant. And the treatment's actually anything that treats a tremor of the hands can also treat tremor of the voice. And at least our neurologists here, when I've sent the patients, have put them on propranolol, which in fairly high doses can be effective moderately. If that doesn't work, we can actually inject botulinum toxin into the vocal cords, which is effective as well. There are other causes of vocal tremor. Obviously, most of us know Parkinson's disease can cause vocal tremor, and spasmodic dysphonia, which I just showed you, can also have tremor associated with it. But far and away, the most common cause I've seen is benign essential tremor. I have an example of this once again, if you can cue the video. This is somebody with benign essential tremor.
Please take from the shape of a long round
Watch her hand. She's got a tremor in her hand and her head.
eyebrow, and it's 2 ends apparently beyond the eyebrow.
So you can see the tremor.
Okay. And now would you just say E and hold it out about 3 seconds?
Listen to the tremor here. E.
I'll have you hold it. And ooh. Hold it.
You see the tremor in the vocal cords? Okay, you can cut that. Most people choose to either go the medication route or do nothing about it. It's not troublesome unless it gets fairly severe. Now the thing everybody worries about is seeing a patient with hoarseness and incorrectly diagnosing it as an infection in the throat or something like that, and it ends up being a carcinoma. But as I'm sure you're aware, anybody that is a tobacco abuser, and especially if they're a tobacco and alcohol abuser, is at risk for squamous cell carcinoma of the larynx. So if you have anybody who's hoarse for greater than 4 weeks that abuses tobacco or both of these, they really need to be referred to an otolaryngologist. And 4 weeks sounds severe. Well, that's not very long to be hoarse and suddenly refer somebody to an ENT. But the truth of the matter is, somebody with a squamous cell carcinoma of the larynx, the hoarseness is often the only symptom they're going to have. I had sign there, but symptom. It's the only symptom that they're going to have initially. It's not until it gets very large that they develop other symptoms like dysphagia or painful swallowing, which is odonophagia, or otalgia, referred otalgia. So just because hoarseness is the only symptom they have, you can't use that as saying, well, they probably don't have a cancer. And the reason to refer early is really if we catch it early in stage 1, we've got about a 95% cure rate, and the morbidity from the treatment of this is very low. But if it progresses to stage 4 disease, and this can happen in a matter of months, the long-term survival is very poor, about 15 to 30% 5-year survival once it gets to that stage. So we really want to catch these people early when we can do something about it. I have another video of somebody.
How often
Yes.
do you see that on patients with a risk factor?
What's that?
Squamous cell carcinoma.
Well, you have to realize I'm only going to get the patients that are referred to me. So there's probably a lot of smoker drinkers out there that are hoarse that don't have it. So it's hard to answer that question since I only get the ones referred that ended up having it. Or that's what I tend to get, at least. But I'm pretty suspicious when I see somebody that smokes that has hoarseness. Very unusual, yeah. This is a T1. You can see the tumor right here.
Take another breath.
You can see it's sort of papillary. There's some redness anterior and posterior to it.
Okay, try this.
You can stop it there. Your question, I'm sorry, I misunderstood you. You said if someone doesn't smoke or drink, what are the chances they could have a squamous cell carcinoma? Very, very low, extremely low. I mean, we see it once in a blue moon, so the chances are low. So those are really of the disorders I see, definitely far and away the most common. So how do we treat these? And this is, I say this because it's not infrequent someone has a paralyzed vocal cord and they've had it for years and they were told nothing could be done about it to make their voice better, and nothing could be farther from the truth. We can treat presbylaryngitis and vocal cord paralysis. We can really treat them the same way. What I do most of the time is a medialization laryngoplasty, which can be very effective in making their voice better. It's actually done under local anesthesia. And we make an incision. This is the laryngeal cartilage here. We make an incision down to the thyroid cartilage, and we cut out a little window of cartilage which gives us access to the vocal cord muscle. We have a little measuring devices that we push in on the vocal cord to medialize it so we can close off that gap that you saw that develops with presbylaryngitis and vocal cord paralysis. And then we custom carve an implant made out of silicone that we place in there. And I have a couple of examples. The first gentleman's presbylaryngitis that had a medialization. The second person had a vocal cord paralysis that had medialization laryngoplasty. And you'll hear before and afters on these patients.
Message passed
You saw this gentleman before.
Its two ends apparently beyond the horizon.
This is the gentleman with presbylaryngeus. Just a brief, I know you've seen him, so this is him 3 months after remedialization.
The vision of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon.
And now his vocal cords are closing, so the medialization on the left resulted in improvement. This next lady had a paralyzed left vocal cord from a repair of a dissecting aneurysm, aortic aneurysm, if you can play that. And you'll hear her voice pre-op. I don't know if anybody knew Ray Mangos. She was...
When I awakened from surgery after repair of the dissecting thoracic and I did not have a voice. And kept going.
So her left vocal cord is paralyzed. It's on the right side of your screen.
My name is Ray Mango.
This is after the surgery.
I this recording from the University Voice Clinic and Reed's Rehabilitation Center. I understand that if I refuse to give permission for the use of the recording,
Can you turn the volume down a little bit?
For evaluation, treatment, and follow-up. I do, however, give permission to the staff to use this in future recordings for teaching, research, therapy, and demonstration.
And now she's got complete closure. Okay.
Some people can't understand.
You can stop that.
It's just,
Okay, you might have to rewind that. The next one I'm going to show you is somebody with spasmodic dysphonia, not a geriatric patient in the video, but this is somebody that's undergone Botox injection to their vocal cords. We do it in the clinic. It's guided by, this is an EMG machine. I have a Botox clinic once a month with Dr. Carlene Jackson, who's one of our neurologists. And we just basically put a little local anesthetic in the neck, and the needle goes transcutaneous up into the vocal cord muscle. When we're in the muscle, we can see it based on the EMG, and we just deposit a small amount of Botox in their vocal cords. The tape I had is actually shameless self-promotion. There's a Kins came down and did a segment on somebody that had spasmodic dysphonia. She's not geriatric, but I think you'll hear the results in somebody that has spasmodic dysphonia before and then after their injections. So if you play that, you'll probably hear only a few seconds of this lady, and then you'll hear her afterwards, after the Botox injection.
Of my normal voice I had before any of this happened.
And rose after this voice I've had for a couple of weeks now. This is the best voice that I've had in probably 3 years, so it's pretty exciting to have it.
You can stop it there. So spasmodic dysphonia, that's the best treatment we have is Botox. It doesn't last forever. It wears off after about 3 to 4 months, and you need a re-injection. Laryngopharyngeal reflux, which I talked about earlier, you can treat them with proton pump inhibitors. You may see some of our patients that have been on this, maybe patients that you're treating for other conditions that you've referred to us, and you may think, well, gosh, that's a really high dose they have them on. But all our literature really supports either the use of 20 milligrams of Paralyzed twice a day, or if you're going to use Prevacid, 30 milligrams twice a day. And it's not that we're going to keep them on that dose the rest of their life, but they need at least 3 to 6 months of that therapy, and then we often try to back them off the medication because it is usually an intermittent condition, LPR is. This next gentleman has LPR. You'll see him before we treated him with anything, and then 6 months after being on proton pump inhibitors. You saw this gentleman earlier. He had the very red larynx, very red vocal cords from LPR. You can see that these are very swollen red vocal cords. He's got some leukoplakia back here, which we thought was related to his LPR. This is him after 6 months of proton pump inhibitors. You can see the redness has gone down, the leukoplakia is gone, the swelling's improved.
Okay, now say he.
You can stop there. So you can see pretty fairly dramatic results on patients that have been on proton pump inhibitors for LPR. And that's really been when we just had H2 blockers, it was much more difficult to treat this condition. And then, again, just to sort of bring home the fact that squamous cell carcinoma, when caught early, squamous cell carcinoma of the larynx is much easier to treat. We can actually, when it's just limited to the vocal cord, we can just do a laser chordectomy, which is basically take them to the OR, put them to sleep, and just take a little cookie bite out of their vocal cord where that cancer is. It's a highly curative condition, and the morbidity is minimal. You'll see this next gentleman is somebody who had, you've seen his video before, he had a T1 small vocal cord cancer, and you'll see him before. The cancer's right there, you saw this earlier. He underwent this procedure where we take him to the operating room. This is the vocal cord under the microscope. We just basically take a laser to take that piece of the vocal cord out. That's all we have to do. We don't have to take out the entire voice box, just a small portion of the vocal cord. And this is him after the surgery, I think a couple of months after the surgery. And he's, I think, 3 years out now from this procedure.
The rainbow is in a division
Still has a fine voice.
Many beautiful colors. This takes the shape of a long run.
He's not trach dependent. Didn't have to have radiation therapy. And what we took out of his vocal cord basically grows back. So you can give somebody a fairly normal voice. They don't have to have radiation therapy. You just have to catch these early. So that's why early referrals are so helpful. So again, to review the red flags of hoarseness. As you mentioned before, anybody that's hoarse that has a significant smoking history, and that could just be 10-pack years, that's significant. It is squamous cell carcinoma until proven otherwise, and you really need to get them referred early to an otolaryngologist just to get a fiber optic examination of their vocal cords. As I mentioned earlier, if somebody comes in with a hoarseness and they have certain associated symptoms, you need to worry more. If they have painful swallowing, odynophagia, we often see that in conjunction with squamous cell carcinoma. This is a warning sign. Obviously, somebody with hoarseness and dysphagia is worrisome for a couple of reasons. These patients, we see a lot of patients that have squamous cell carcinoma that present with those two symptoms, and also somebody that's had a stroke will often have dysphagia and hoarseness secondary to a 10th and 9th cranial nerve paralysis. Aspiration, as I mentioned earlier, if somebody has hoarseness and aspiration, that's very suspicious for vocal cord paralysis, and that person needs to be referred to an otolaryngologist for two reasons. One, to confirm whether or not they have a cord paralysis, and if they do, that needs to be worked up because they could have a tumor in their lungs or their mediastinum that's causing that. And the last one, I was hoping I would get a video segment of this, and I didn't, but anybody that presents with hoarseness and dysarthria, articulation problems, this can be a real red flag for a neurodegenerative disease like ALS. I've seen a number of patients who presented with nothing more than hoarseness and dysarthria, and usually I'm not good at diagnosing these conditions, but I send them to Carlene Jackson, who's our movement disorder specialist here at the Health Science Center, and we found several ALS patients that presented with nothing more than hoarseness and dysarthria. So that's a red flag that needs referral. And that really completes the talk. Again, just listing the 7 most common things you see with hoarseness in the elderly population. Are there any questions?
Those patients with esophageal reflux, do they present just with the hoarseness, or they have any other symptoms? I mean, how?
They usually have a constellation of symptoms.
Okay.
Hoarseness is one of them. Although they may have no complaints of hoarseness. The most common ones I see are globus sensation, feeling of a foreign body in the throat. And this sounds crazy, but they'll complain of postnasal drip. They feel like they have this drip down the back of their throat. But if you ask them carefully, because that sounds like allergies, and often it is, but ask them carefully, does this drip ever come out of their nose? Do they have anterior rhinorrhea? Do they have nasal drip? Most of them will say no. I just feel it dripping down the back. Well, oftentimes that's just they just feel something in the back of their throat, and it's actually acid reflux coming upwards. Those people do not have heartburn. That's the thing that can throw you off. You'll think, well, gosh, it's reflux. They should have heartburn. Only about 20% of our patients with LPR have heartburn. So hoarseness, globus sensation, sensation of postnasal drip, and throat clearing. Those are the most common ones. Some of them have cough, which you're probably familiar with, chronic cough being a possible manifestation of reflux. But those are the ones I tend to see. And they're mistaken for allergic disorders. I have a number of patients come in on antihistamines and nasal steroids with this sensation of drip, and all they end up having is LPR, acid reflux, up into their larynx, into their throat. Interesting disorder. I see a ton of it. You have to see a lot of it to become a believer in it, but it definitely exists.
What about the singers and the, do you see those people having more problems out there?
Yeah, singers, it's probably about 10 or 15% of my practice are semi-professional and professional singers. And was your question, do they tend to have reflux? Or?
No, I guess they have a lot of laryngeal problems and vocal cord problems.
Yeah, the ones that are not well trained. As it turns out, if you're a trained opera singer, you know, most of those people know how to avoid getting themselves into trouble. You know, they know good breath support. They know how to drink lots of water to keep themselves hydrated and avoid that dry state of the larynx that I was talking about earlier. And it's the ones that are pop singers, maybe that didn't get as much training, singers in, Fiesta, Texas. I see a number of those who maybe are dancing and singing and maybe not using the best technique. And they're the ones that tend to get into trouble. Before I was here, I was in Nashville for a year and of course, country western singers are notorious. They're the worst because they don't have, as a rule, they tend not to have, formal training in voice, and their schedules don't permit them to do all the things you need to do to have good vocal hygiene, as we call it. There's a lot of smoking and drinking going on, apparently, in the country western population, but that's basically it, unless there's any other questions.
Thank you so much.
Thanks. Appreciate it. Thanks. You did a fantastic job, because that was not a well-edited tape at all. I think you've always done a good job when you work with us on our grand rounds, too. We appreciate the excellence.